on yoga therapy for irritable bowel syndrome. He'll be discussing the clinical study that is being undertaken for effective integrated management of IBS through yoga.
Good afternoon. It's indeed a great pleasure to share with some of our work. I thank the organizers for putting wonderful quality work here. Quality is not an accident. It's a concerted effort involved. I'm very thankful and then the warm hospitality. This is work. I come from a modern science guy. I've been 30 years of working in modern science. 2 years back, I had my personal experience, downfall of physical health that led to get into yoga. Phenomenally, like many of us shared last 2 days, the personal experience that's what's otherwise our. But the challenge is, how do you take these personal experiences to make it more acceptable than practitioners, modern clinicians? I've been involved with a lot of clinical trials and other things. Whenever you talk about yoga, they always subjective and it's not going to work, all kind of thing. Then people like me, coming from modern science, we always want to have an objective, evidence-based, quantified data. Dr. Navin pointed out some of the challenges with regards to meditation. That is, sometimes things cannot be quantified, certain changes. But there are other cases, but there's a limitation of the technology we have maybe. But there are other cases you can quantify some of the things which Dr. Khalsa has pointed out yesterday very candidly. And that is the reason what we thought, why can't we take some studies which we can quantify and then demonstrate whether indeed it's happening. Some of this work, preliminary work has been done in SPSO for many years, but still, when recently Guruji was visiting my institution, still people question asked, looking at the publications and the data, it's not quite convincing. We have to be self-critical of our work. And that is what led to this better undertaking for me. I'm a full-time scientist. I do as a enjoyment and tremendously enjoy. I wish maybe down the line I'm going to be involved 100% from my yoga research. That's why I go to bed sometime 1 o'clock and then get up 4 o'clock. My night time is for this, daytime for my other work. This work would not be possible. I would say this LA Vyasa is a whole team. The Vyasa is a chapter of, LA is a chapter of SPSM, and we are like a Houston center. But this is the first study. If you remember, the study which they started in MD Anderson, this collaborative study funded by NIH through MD Anderson. Then we thought, why can't we the sponsor of a study and we conduct the study? And blessingly, this is what happened in a collaboration with the White Memorial Hospital in Los Angeles. This is a study we're going to undertake. First, let me acknowledge, first I may run out of time. It would not be possible without clinicians' cooperation. We have to convince the clinician cooperation, come in partnership with us. That's key. If we go through clinical study. And also we have a wonderful trained committee after having 2 kids in college, the yoga therapist and researcher. Without her, I would not have start connecting this very hard. I would give a strong credit to her, and also wonderful students. She's going to get this work done, and also get a PhD. That's what you're hoping for. I also want to thank all the members of the team for their support. We cannot even conduct this. So even doing the project takes a lot of manpower. And then our leadership, Chakrabani, I like to recognize our team is sitting here. Chakrabani, Babu Gandhi, Vikbhai Patel, they are in the leadership for us. And also Nagendra and the doctor, logistic for conducting the study. And it would have been possible without philanthropic support. No money, no mission. I kind of characterized the content, the planned out the talk this way. I first defined what is the Irritable Bowel Syndrome. I just touch upon what is the prevalence and then classification. Then I'll touch upon what the future trial will be. If you look at Irritable Bowel Syndrome, it's a disability. Look at here, this is the status you go through. You cannot express yourself, you are having this disease, you are confined in many cases. I'm sorry, yes. There is a situation, grave situation. And if you look at the simple definition, what's really happening with the IBS is it's basically an abnormality in the intestinal muscle contraction because somebody is squeezing your intestine. If you look at more so in detail, it is a disorder of common condition of the digestive system. It is not a disease. It's a group of, when you call it syndrome, syndrome means comprises symptoms and signs that occur together in a chronic and episodic way. It comes and goes sometimes. You may not even realize you have this disease. And then causes bouts of, what are the characteristics? Stomach cramps, bloating, flatulence and gas, and then diarrhea and the constipation. What are the incidences? Affects as many as 1 in 5 Americans, making it one of the most common ailments diagnosed. I want to focus here what's happening in the US. Also, it's more common in women than men, or 2 to 1. In about 50% of the population, it strikes before the age of 35. And if you look at classification, it's a kind of very difficult to classify. It's again a little bit subjective here, but they classify it as 4 different cases. One is IBS with constipation, diarrhea, and you have to look into the sub-categorization. What is the characteristic of each category? And then it's all mixed type also with the diarrhea and the constipation thing. And also unsaid category, so less than 25% of any of the situation like the hard or not stools or loose or watery stools in case of diarrhea. If you look at pathophysiology, what is it's a very abnormal GI, it's a GI motility for altered, intestinal secretion, and then visceral sensitivity. It's basically a functional abnormality. If you look into the morphologically, they are normal. The color is normal. But it's functional changes that is what leads to this disease. And if it has a strong neural connection, as we have been talking in many of the talks here, all the 3 involve bilateral interaction with the brain gut axis, which links the brain and the spinal cord, the central nervous system, with the enteric nervous system, which I call it as a mini brain. You can see at a gut level. When you have some anger, something like that, you feel it here. There is a 2 brain system you have to recognize when you want to talk about this disease. I just want to touch upon it more. If you have a stress, for example, mood disturbance, stress, anxiety, depression, that lead to central nervous system change and autonomic nervous system affecting enteric nervous system, which connects with the smooth muscle cells. It's basically smooth muscle cell disease here. And that's what it happens. And again, it's holding a triangle, actually I'll show you here. One other thing, there are many things happen during the neural brain network involved from neurotransmitters and neuromodulators. The particular one which heavily involved people associated with is serotonin. The serotonin is basically involved in hostility, anger, and aggressive behavior. And more so, the serotonin which is produced and stored mainly in the gut, 90%, has been believed to play a primary role in the development of syndrome. The modern medicine, what they try to do when they identify like that, oh, let us target the serotonin. And that is what they try to follow the 2 different receptors here, but with some antagonist or agonist. But still, it doesn't work. The disease doesn't work. What I'm trying to allude here is modern medicine goes into reductionist approach and trying to identify something. Aha, this we can fix this one, everything can be solved. That is not the case. If we add further dimension to this irritable bowel syndrome, like in the earlier mentioned, you are involved with the muscular, nervous, and immune, which immunology is one of the favorite field. I've been working for 30 years. It causes inflammations, and inflammation can lead. And also people think there is a bacterial association. If you have bacterial infection, that can also go. And also, if you take a gluten causes celiac disease, and that can also lead to IBS. And I try to put together this slide show that you have a food sensitivity, imbalance in flora that I talked about, the other factor, environment, and then endometrius. So there are so many other things that lead to IBS. the conventional treatment, just to make a statement here, they try to change it. If you have a problem, they say change the diet, and then nutrition, medication, probiotics, even psychotherapy, antidepressant, many things they prescribe. But still, the problem, if you look into the people who seek the alternative approaches, tremendous. Many great number of people they seek alternative medicine because they don't get any benefit from the modern medicine. Then what are the other alternative medicine people try? Exercise, acupuncture, hypnosis, and yoga. If you go and click PubMed, in fact I do have it. If you click, why I'm stressing here is importance of research is, if you click in PubMed, IBS and TAM, you only get 11 papers. And I'm not talking about quality of the paper, I'm just talking about the number here. IBS in alternative and complementary therapy, there are 29 of them. IBS in yoga, only 7. IBS and hypnosis, 53 papers. And IBS and antidepressant, around 77 papers. I think what they were. Even the hypnosis, the problem with the hypnosis, you cannot practice it very easily. It's very difficult. But yoga, you can do it. I've been doing that for 2 years. Phenomenal. Once you learn it, it's become part of you. That's what I want to try to highlight. There are two aspects of it. Touch upon exercise and yoga. I'll touch the what is the current status. Then I'll allude you with our present work. There is one study which has been done recently in 2010. They looked at the exercise and how that can modulate IBS. Unfortunately, most clinical trials have been of poor quality. That's what I'm trying to underline here. The efficacy of the therapy has not been adequately elucidated, even though systematic reviews and meta-analysis. There is also general lack of understanding of the mechanism of action. This is another key problem. Currently, insufficient evidence exists to support the use of traditional Chinese medicine, acupuncture, meditation, and reflexology for the treatment of IBS. That is the biggest challenge. Then, the exercise, there is a recent study, this is 2011. 102 patients, only 75 completed. But this study, they say exercise can improve 51 points versus control with 5 points in terms of symptom scores. But the limitation of the study is the result with quality of life, anxiety and depression and fatigue that are required to have sustained benefit were not significantly changed, which in my mind can overcome outcome. The study mentioned that diary was checked but does not provide average time of physical exercise and type of exercise. But if you look at here one point, then whosoever is conducting the physiotherapy, they give an instruction on the phone. How do you know that how much they are doing? And the question arises, if IBS patient can do cardio exercise given their distance. It's a strenuous exercise. That is a problem. I'm trying to pose some problems here. Then this is a study on yoga, which on adults. It's a very small number of patients they've been used in this study. Male adults, most adult they've used. In fact, it's equivalent in women. And yoga group 9, control group 12. Yoga intervention for 12 postures and right nostril breathing twice a day for 2 months. Control group and they have lopromat, that's for diuretics, mostly they use the diarrhea patients. This is the first randomized trial using a yoga as an intervention to improve the symptoms of IBS. Establish a good standard for future study. That's all I can say from this study. Limitation is monitoring of the yoga session was not done. No journal maintenance. We do not know whether people practice. And then diet was not mentioned. Quality of the life was not measured. Study limited to male population, even though prevalence is 2:1 to men. That led to designing the trial which I will planning to do. Basically, we followed the IAYT, which Dr. Naratana has elegantly alluded yesterday and even today. We took their guidance. Our hypothesis was IAYT can influence at physical level, physiological factors, but also psychological factors. So all can make it. But IBS, if you talk about all the 3 things, changes in these 3 things can affect the IBS, result of IBS. We thought we should look into those factors. we have a subject design and intervention and outcome measures. And then we selected a population of, for subjects, allowing 40% active attention rate, the sample size of 108. We have 3 groups here, 36 in yoga group, 36 in combination group, and 36 in wait-listed control group we have planned. And then we have a inclusion criteria. We follow the Rome 3 criteria. That's a standard criteria we follow. For lack of time, I'm not going to go over everything. And then not enrolled in any other alternative medical program, not practiced yoga in the last 6 months, able to maintain a journal for dietary intake, and then do the practice. And we eliminate some of the people who has physical disability to yoga, pregnancy, and also mental disability to yoga. And then there are 3 measures. We have 12 weeks yoga intervention, of both here yoga alone, yoga plus conventional treatment. Whatever the treatment they are taking, they can go ahead. Here they go through conventional treatment, then we put them back in yoga group after a period of 12 weeks. And then we are planning to do the analysis baseline, 6 weeks and 12 weeks. That is at the end of the plan. And existing treatment, this is what waitlist group I mentioned here. And they will go through diet counseling, maintain a daily dietary intake journal. After 3 months, as I mentioned, they will be back from yoga group. Basically, we following just a route here. There's 60 minutes of yoga each practice under the guidance of the yoga instructor and therapist. Weekly thrice for 12 weeks. Yoga counseling include diet and happiness analysis, happy assembly for an hour. In case of observed necessity, conventional treatment will be used for yoga only group, and the patient will be moved to the combination group. We have to have a room there. And then this is a structure we have created. 1 hour breathing, it's a relaxation technique, sleep. I don't need to go through all the thing. And it's a basic workout we have from the SVSR. But the important thing is we need to make sure we're not creating one module that fit everybody. We have to, because there are 2 kind of diseases we have, diarrhea and constipation, then we have to kind of cognizant about there are certain things that can be done by diarrhea, cannot be done with constipation. And there in more abdominal twisting asanas for involved with constipation module to activate digestive power. Uddiyana Bandha and Agnisara are also performed to activate digestive. Diarrhea module, more abdominal stretching asanas to soothe the digestive tract. Uddiyana Bandha and Agnisara to be avoided. And then meditation, pranayama, there also. And then we are planning to do the bowel symptom score and IBS quality of life. That's a primary objective measures. The secondary objectives are BMI, physical flexibility, autonomic function, state and anxiety. And then body mass index we do, and then the range of motions from hip, front and hip and shoulder, using like the in terms of physiological evaluation, we have a series of things which Dr. Navin talked about, looking at even heart rate, variability, and also blood pressure. That's very key component. I'll be done in a few more slides. We look at what autonomic function with 2 testing and also 4 tests, which involve for measuring the 2 tests for sympathetic reactivity, that is mental arithmetic math as well as a hand grip test. And also for parasympathetic, we do the heart rate variability at 30, 15 upright posture. And also heart rate variability in response to deep breathing, which again we are looked at here. That's what we are planning to do. And then for anxiety evaluation, we are going to use the state tract anxiety inventory that's published in this standard questionnaire we are going to involve. And also quality of life evaluation, we use IBS, quality of life, developed by Patrick et al. In 1998. And we also going to look at other parameters like age, gender, education, economic status, because some of the population is going to be Hispanic populations. That's a very important component. And that is what we are planning to do, and then the trial is going to be started, and we have everything in place. IRB has approved. We have put in all the logistics. November 1st week, we are planning to recruit patients arriving right now, and that is what I can share with you. I'm sorry, maybe next meeting, I'll be in a position to share some of the many findings. And what the yoga can benefit you here it is. first the practice can bring, this is key, which have been time and again stressed by many speakers here, can bring awareness that something is out of balance. Then the asanas, pranayama, meditation, etc. become specific tools to bring the system into balance. That is what we need to achieve if we want to find a cure, not just medications or quick fix or with the reductionist approach to solve issues. And if you don't do it, this is what happens. I divorced him after I discovered that when I eat alone, I did not get clean digestion. That is again stress related. This is what I need to focus here. I want to find me implanting my cavities, but carrying little for it and much more for it, keep my imperfect thought. And why I share this one with you is, we all come up with, even Dr. Navin pointed out at the beginning, we all come up with the goodness in us, everything. What we accumulate is the dust. If you remove the dust, the goodness you don't need, it's revealed itself. And that is what I would like to share with you. If you have any questions, please. Thank you.
Is it just at one center or multiple centers?
This is a one-center study. What we are trying to, that's a good question, because we want to have none of this, we have SVS centers here. No center has really put together a study. We all do as a personal basis. I was listening to Ashwini and other people. We do at the personal level, therapy, but we case study. Even the case study, in fact, I published a case study following one patient for 8 years. I published a paper in Leukemia Research in some of the different contexts. But we need to methodically follow. Quality is important. Not just, okay, I did this person feeling better. We have done that. It's a time to put together a systematic program. That is what I'm trying to make a case here. And who can do? We have to bring in people. Scientists. If scientists have to do, not because I'm a scientist, I'm speaking for them. In order to clinician, we take it to the clinician. Clinician should speak like Dr. Dev Shankar can tell. He's a clinician, he can speak to the clinician. That's true. But if you go with the evidences, it's going to speak for itself.
Last but not least, we need the funding.
Yes, no money, no mission. Dr. Khalsa pointed out beautifully yesterday. And that is why I tell you, this is a community effort, a small community level, with giving time and energy to you all doing it, giving your personal time, not paid or anything. And that we have to start something. Then once you so small, steady, sure, then we can get money. Without doing that, you keep asking, oh, yoga works, we know that, it's been at 5,000 years, why it's still the same step? And we have, I think, if you put our bill, there is a money will come. It need to happen here. That's all I can say. But it has to happen on a large scale. We are very, not in a very boasting ourselves, proud to say that it's the #1 trial putting in America. We have to, if you want to take the American audience, we cannot take SPSR data and show them to do that. Okay, MD Anderson could do it, one center. We have to make it like a banyan tree. We have to make branches, empowering, and many centers have to do like MD Anderson. And then only we are going to have a step.
The man who loved yoga now gave $15 million to University of Virginia.
See?
Yeah.
Yeah.
So
We have to know how to tap into it. Thank you,
How many
Dr.
agencies together? Thank you so much.